2020 saw a great deal of change as a result of COVID-19. COVID-19 dominated the headlines, of course, and in terms of the pandemic, we know that this was not just a respiratory pneumonia, but also a multi-system disorder that caused a great deal of morbidity and mortality. The liver is no exception in this regard, and what we saw was that COVID-19 does very much affect the liver. We know that the virus that causes COVID-19 can infect the two cell types within the liver, including the hepatocyte and the bile duct cells. And we know that abnormal liver tests are very frequent in patients with COVID-19. In hospitalized patients, we see elevations in liver tests occur in over half of patients. And some studies have suggested that an increase in liver tests may portend more poor prognosis for those patients. We've also seen that patients with chronic liver disease, particularly those with cirrhosis, appear to be at higher risk for adverse COVID-19 outcomes, including a risk for acute and chronic liver failure, but as well an increased risk for adverse COVID-19 outcomes in general. Particularly at increased risk are those patients with decompensated cirrhosis, that is to say liver disease that has already demonstrated organ dysfunction. Alcoholic liver disease appears to be a specifically increased risk compared to other etiologies of liver disease. And patients with hepatocellular carcinoma also are at increased risk for adverse outcomes. Additionally, fatty liver may be associated with adverse outcomes, but this is a difficult entity to separate from the very frequently associated conditions of diabetes and obesity, which themselves are independent risk factors for more severe COVID outcomes. So ongoing study is going to be important for us to understand who gets sicker with COVID-19, and we will also need to understand exactly what impact COVID-19 will have on those patients with chronic liver disease who survive COVID-19. Will their liver disease be on a worse trajectory? Either way, the existence and availability of vaccines will be incredibly important to apply to this group of patients as a whole because of their specific increased risk. 2020 saw improvements in other fronts. We saw improvements in treatment for hepatitis B virus. We know, of course, that there have been significant improvements in hepatitis C in terms of the development of breathtaking curative strategies for hepatitis C. And the field as a whole has asked itself, well, if we can cure hepatitis C, what about the strategy of curing hepatitis B, which is a very, very different virus. But as we understand the viral life cycle for hepatitis B, we can understand that there are other steps that have not been targeted historically, which can now essentially be targeted for the development of new small molecule antiviral agents that could theoretically increase the likelihood of HBV cure, or what we call functional cure, the loss of hepatitis B surface antigen. In this regard, we've seen advances across several different fronts in terms of specific inhibitors of specific life cycle steps, including the development of inhibitors of virus entry, which have shown real promise in helping to prevent viral infection of liver cells in the first place, the development of RNA inhibitor strategies, or RNAi, which knock down viral protein production. And this may have benefits from the vantage point of not only knocking down viral replication, but as well knocking down viral protein production, which itself may be associated with suppression of host immune responses against hepatitis B. So we've seen a number of different RNAi compounds that have been developed, all producing promising reductions in hepatitis B surface antigen levels, and in doing so, in some of these cases, in a rather sustained manner. So there's promise potentially for this class of compounds. And a related class of compounds called antisense oligonucleotides, which again accomplish reduction in viral protein production. There's another class of inhibitors called capsid assembly modulators, which block virus assembly. And we've seen several candidates in this class knock down viral replication, as well as potentially improving or modulating other steps in the viral life cycle, because the capsid protein is involved in several discrete aspects of the virus life cycle. Therefore, is an attractive target for inhibition. And then a fifth compound or class is so-called nucleic acid polymers, which block surface antigen secretion or block their release into the circulation, and in so doing, again, might reverse or rejuvenate immune responses that would be suppressed by the excess quantities of surface antigen in the circulation. So we've seen in 2020 significant promise for several classes of therapy against hepatitis B, which ultimately potentially could be combined with one another to improve the likelihood of functional cure. Yet another approach that was tested in 2020 and in years prior to it, showing again potential for promise, would be actually taking patients who had been on suppressive antiviral therapy with our currently FDA-approved compounds known as HBV polymerase inhibitors, which produce excellent rates of suppression, but do not accomplish cure of hepatitis B virus or only do so in an extraordinary minority of patients. It may very well be that in selected patients, withdrawing or stopping these so-called nucleoside analogs or polymerase inhibitors after a prolonged period of suppression in some of these patients may be associated with spontaneous control of viral infection off of drug. And in a subset of patients who had low surface antigen levels, this may be possible and lead to surface antigen loss in a subset of patients. So this withdrawal strategy might be applied successfully in a subset of our chronically well-suppressed patients. I mentioned hepatitis C virus and really the breathtaking cures that have been developed over the last several years continue to advance in terms of their application to infected patients all over the world. And we're hoping to accomplish, of course, elimination of new hepatitis C cases by the year 2030. One way to help accomplish that is really to simplify therapy, to get therapy to as many people in perhaps more resource-limited settings as possible. And 2020 saw a study where essentially we could get away or accomplish successful rates of cure using a minimal monitoring strategy in which patients were simply given all of the antiviral therapy up front for, in this case, 12 weeks, and not monitored with study visits, not monitored with blood draws, but really allowed to take the entire treatment and then come in several weeks after that to document cure. And so this simplification of therapy is possible with very high rates of success and excellent tolerability compared to our approaches of monitoring patients during treatment. So in resource-limited settings, this may be a strategy that might allow many more patients to be successfully treated. We also have seen that in active injection drug users who are in many ways the spreaders of hepatitis C virus today, they transmit virus from one person to another through injection drug use and shared paraphernalia. It turns out that treatment of active injection drug users is not only possible, but can be done again with very high rates of success. And this can be accomplished with either directly observed therapy in this group of patients, or potentially with the use of what we call a patient navigator, who is someone who helps guide these patients through their treatment, in some instances remotely. And so it is quite possible then that even those who are at greatest risk of spreading hepatitis C virus can be successfully treated and potentially diminish the rate of spread of hepatitis C, a very important concept moving forward. In the area of fatty liver disease, which of course may be the world's most common chronic liver condition, we saw, 2020 saw promising data for a number of different classes of therapy, giving us hope that we will soon see approvable agents for the management of non-alcoholic steatohepatitis, or NASH. We saw several treatments along classes that work on metabolism to result in decreased fatty acid and triglyceride production within the liver cells themselves. And they work across a variety of different mechanisms, one of which is called glucagon-like peptide 1 or GLP-1 agonists, which historically have been approved for diabetes. It turns out that this group of agents, again, particularly in diabetics with NASH, may be promising in terms of their ability to bring about improved fatty liver improved inflammation, improved scarring, and even weight loss. So too have there been the development of what we call fibroblast growth factor 19 analogs, which again were associated with encouraging rates of resolution of NASH and improvements in scarring or fibrosis in those patients. FGF21 agonists, yet another mechanism by which steatosis or fat can be reduced, also resulted in improved steatosis and resolution of NASH. And the use of a agonists of a pathway called PPAR or PPAR have been used again successfully in early clinical trials in NASH, again with improved rates of NASH resolution and potentially improvements in fibrosis or scarring as well. So much encouragement in terms of agents that and classes of agents that may improve the state of affairs for patients with NASH. And so we have much to look forward to in terms of treatments that will be successful in that vein. And then finally, in hepatocellular carcinoma, we have historically had a great deal of difficulty in terms of really improving survival in patients with HCC, largely because HCC develops in patients who already have cirrhosis in over 80% of cases. But we saw extraordinarily encouraging results using advances in combination therapy in persons who have unresectable forms of liver cancer or HCC. And these combinations use essentially two classes of therapy. Inhibitors of checkpoints or anti-PD, in this case, anti-PD-L1 in the form of a medication called atezolizumab, and a second agent that blocks what's a growth factor known as VEGF or vascular endothelial growth factor called bevacizumab. This combination of atezo and beva in a randomized trial compared to the prior standard of care for treatment of unresectable HCC known as sorafenib resulted in nearly 50%, specifically 42% improved survival compared to sorafenib in patients with unresectable liver cancer. So this has now emerged, this approach has emerged as really our new go-to therapeutic approach for patients with unresectable hepatocellular carcinoma. And so this is really a significant advance for all of us in terms of our patients who develop HCC as a major complication of their chronic liver disease. So that's a little bit of a roundup of some of the great improvements or great advances or encouraging advances that we saw in the year of 2020 in liver disease. Right, great. So these are important questions. So I think what's absolutely clear is that for both hepatitis B and hepatitis C, that either curing virus, as isn't the case for hepatitis C, and suppressing the virus, as is most often the case with hepatitis B, are associated with real clinical benefit. And that's not just improvement in the rate of cirrhosis and the rate of decompensated liver disease, but just as importantly, the rates of hepatocellular carcinoma. So for instance, with hepatitis B virus, we know that patients who suppress virus with nucleoside analogs or polymerase inhibitors, as I described earlier, that in patients who have non-cirrhotic hepatitis B related disease, that risk reduction is about 80% for future development of HCC in persons who are suppressed. Moreover, in patients who have cirrhosis or an even higher risk for liver cancer, that rate reduction in those patients who are successfully suppressed with antiviral therapy is about 30%. So clearly there are benefits to suppressing virus. Now, if you can succeed with loss of surface antigen or functional cure, which we can't do in the vast majority of patients, but we hope to do with newer therapies, we have already seen that persons who lose surface antigen may actually have an even greater benefit in terms of the reduced incidence of future hepatocellular carcinoma. So, so we should still endeavor to develop functional cures for hepatitis B insofar as reducing those future risks of HCC. Now, for hepatitis C virus, we can cure these patients, as I described. And for patients with cirrhosis who are at the highest risk, or advanced fibrosis who are at the highest risk for subsequent HCC, we do know that even cure of hepatitis C does not fully eliminate that risk moving forward. So these patients need to continue to be monitored for the subsequent risk of HCC if they have advanced fibrosis. So, but we do know that the risk reduction for HCC is still significant. Most studies suggest a reduction of risk of about 75% in patients with cirrhosis for their subsequent development of HCC. Put another way, we're reducing that risk by 3/4. And so it's not 100% reduction, but it's pretty close. So we can say to our patients that we will reduce their risk dramatically, but still they still require monitoring and surveillance for HCC moving forward. Well, so the most important risk factor for subsequent development of HCC after elimination of viral hepatitis is really the state of cirrhosis. So if there is cirrhosis, particularly advanced cirrhosis, which can be assessed through potentially elastography or can be assessed clinically based on the appearance of the liver or even potentially through the existence of decompensation. These appear to be associated with the highest risk for subsequent development of HCC, even after cure. There are other factors. Age, diabetes appear to be also important risks for the subsequent development of liver cancer. The coexistence of fatty liver or heavy alcohol use, in other words, cofactors in HCC that are also important in the subsequent risk. It's hoped that ultimately that there will be developed markers. We don't have them yet, but markers that can help prognosticate that risk in those patients who have cleared their virus, but we want to assess who is still at the highest risk. And these may be related to the potential gene expression signatures or defects that persist in some of these patients even after elimination of the virus. I think the main thing there is going to be intensifying surveillance. In other words, selecting those patients who we view as being at particularly high risk. So separating the high risk patients from the low risk patients and taking those high risk patients and subjecting them to more intensive surveillance. I think that is the best way we're going to arrive at early detection and therefore treatment of those patients who subsequently develop HCC. I think the other possibility, which is something that we are hoping to test in prospective controlled trials, would be the use of chemopreventive strategies. In other words, even after eliminating the virus, taking those patients who might be at increased risk and applying other treatments that might subsequently reduce the risk of that patient for developing hepatocellular carcinoma. And there may be some promising approaches to looking at using commonly used agents like for instance, statins as an example. I think we can't really diagnose HCC without an imaging modality. That's critically important. And I think we're going to need to eventually find a way to get any patient who's at risk access to imaging. Because it's very hard to make a diagnosis of HCC without imaging, because you really need to see the tumor and you need to understand the extent of the tumor. And so what I would say is if somebody's got abnormal biomarkers, it's going to be very important to get those patients to some form of imaging. The more sensitive, the better. If we think we see biomarkers that are concerning. So I do think that all this, I think, rests on an important imaging approach. Even in those patients for whom we do things like circulating tumor cells and other more sophisticated biomarkers, I think at the end of the day, we're going to need to understand the extent of the tumor to help manage it most optimally. So I think imaging will be critical at the end of the day.